Good afternoon, everyone. My name is Dr. Tracy Newman, and I am a pediatrician, and I serve as the medical director here at the North Dakota State University Center for Immunization Research and Education, or CIRI. Today, I have the pleasure to introduce Dr. Elizabeth Skoy and Andrea Polkinghorn, who will be presenting this webinar titled Supporting Vaccine Decisions Through Shared Clinical Decision Making. Our first speaker will be Dr. Elizabeth Skoy. Dr. Skoy is a professor at NDSU and a community pharmacist in Fargo, North Dakota. Her areas of expertise include immunization delivery and increasing immunization rates, prevention of opioid misuse and accidental overdose, innovation in instruction, and helping improve health access in rural areas. Dr. Skoy has provided her expertise to various agencies, including the FDA, CDC, NIDA, and the American Pharmacists Association. Currently, she serves as the director of the Center for Collaboration and Advancement in Pharmacy at NDSU. She has also served as the APhA representative on the ACIP workgroup for adult RSV vaccine. We are honored to have her expertise today, and after her presentation, we will introduce our second speaker, Andrea Polkinghorn. Dr. Skoy, welcome. You can begin.
Thanks so much, Dr. Newman, and thanks everybody for having me today as we talk about this important decision of supporting vaccine decisions through shared clinical decision making. So as we kind of go through today, just to start off, the common disclosure slide. So I do not have any relevant financial relationships to disclose today before we have our presentation. And in the realm of shared clinical decision making, I think it's kind of important to understand why is this really such a hot topic. As we'll talking about in a little bit, shared clinical decision making has been around for quite some time, but more recently this has been a conversation and a term that is popping up a lot more in conversations related to healthcare. And this really comes down to what happened in the beginning of 2026. In the past, vaccines had kind of undergone kind of a rigorous process when the recommendations had come down from the CDC as to, the vaccine schedule and how vaccines were to be administered. But there was a number of specifically pediatric vaccines that in the beginning of the year came with a shared clinical decision-making recommendation. But this recommendation didn't follow the historical context and the historical normal process of recommendation. The normal process of using a framework and guided recommendation accepted by the CDC has a little bit gone away now, and is having a new approach under Health and Human Services. And so we're going to be going into a little bit more detail about that, but overall, that's kind of why we're talking about this more, and why I think that there's also been just a lot more confusion and people wanting to talk more about shared clinical decision making and how that relates to healthcare and our practice as healthcare providers. So here's our objectives for today. I'm just going to pause for a moment and give you some time to read through those. And then we're going to just start off right away with just kind of defining shared decision making and understanding what shared decision making is. So there's a few definitions out there, but the definition I think that represents what we're talking about today and represents in the world of vaccines is shared decision making is an approach where clinicians and patients share the best available evidence when faced with the task of making a decision, and where patients are supported to consider options to achieve informed preferences. So as we go through this, it's important to kind of understand in that definition how we applied shared decision-making in our roles as healthcare providers. So one thing to understand is when you have true shared decision-making, there are two experts in the room. There's the healthcare provider, which is probably you who might be listening today. You're a healthcare provider and you are an expert in that contents of recommendations, treatment, preventative measures in the context of your education and your knowledge of healthcare. But there's another expert in that room, and that other expert in that room is the patient or potentially their parent or their caregiver. And when shared decision-making requires two-part participation. There needs to be patient or caregiver participation, and there needs to be provider participation as well. And information is shared between those two. So again, information on healthcare from the provider, information of preferences, lived experiences, health history, goals of treatment and prevention from the provider. And then they come, or from the patient's perspective, then they come together and build consensus on what the next step forward is. And then they agree upon a plan. It's also important to note that in shared decision making, there is equal sharing of power. So in a lot of contexts, when we talk about healthcare, most of the times the provider is looked at as kind of a higher level of power. We're usually telling the patient maybe what they should do. Patient is determining whether or not they want to go along with that recommendation. We're working together. But this is a little bit different. There should be equal and shared power when true shared decision making is taking place. There's a couple of ways that shared decision making is historically taken place in healthcare. One is sometimes guidelines specifically call for shared decision making. And one example of that is in vaccines. We're going to get to that in a lot more detail here in a little bit. But there are sometimes that guidelines or schedules, as vaccine schedules, call for shared decision making to take place. Another example is when a patient is not following an original treatment plan. Now, that's very different than the patient is not doing what we told them to do. Okay? So it's a little bit different, meaning that if a patient isn't following a original treatment plan, going and utilizing shared decision-making to collaboratively come together with the best treatment option. And then a lot of times, shared decision-making is used when there's more than one treatment option available. Probably one of the most historical contexts where shared decision-making has taken place in healthcare is in the field of oncology, where sometimes a treatment option means no treatment. And so determining, working with the healthcare provider and a healthcare team and the patient, determining what the quality of life outcomes should be, life, quantity or longevity of life, coming together to come up with the best option for them. So there's also kind of more of a colloquial definition of shared decision making. So that can be like when the patient or parent or caregiver is involved in the decision making process. So when we talk about that, just when we look at think of, okay, well, they're involved in that. It's always recognizing that it's always the patient's decision, but it's whether or not they're going to accept our recommendation as a provider or not. However, in that true medical definition of shared decision making, it is, again, more of that collaborative discussion. Benefits and risks are still discussed many times in both situations, but there isn't always one best option. Okay, so a lot of times when we're trying to have the patient just involved in the decision that we're trying to, get them to do or we think is best for them, they're always involved, but they're involved in a much different level when true to shared decision making. And there isn't always that one outcome that we're going for. So here's an example of kind of, we could look at, shared decision making as an example here of a blood transfusion. So if a physician recommends a blood transfusion to a patient, and they recommend that they should have a blood transfusion. They explain the need, why they need a blood transfusion. They also explain the risks of that blood transfusion, answer any questions that the patient may have, and then obtain consent for that patient to have to actually have a blood transfusion. Well, if you look at that, you could easily think, well, that's shared decision making. The patient was involved in deciding whether or not they had the blood transfusion, and that's actually not really true shared decision making. That would not be a true example of how we want to apply shared decision making in practice, because that is more of like an informed consent or more of a just having the patient just involved in the recommendation that we are giving them. So then how do you implement shared decision making into practice? Probably the most cited and recognized model for shared decision making in healthcare is called the 3-talk model. This has been around for a number over a decade, has been widely cited in the medical literature, was originally published in the British Medical Journal. And the 3-talk model involves 3 portions that are equally important and kind of are ongoing and continuous. That is team talk, option talk, and decision talk. So we'll break these each down in the next few slides. So the first is the team talk. So in team talk, you have to agree with the patient that a decision needs to be made. So in the example of vaccines, you would talk with a patient or a caregiver that we need to come together and determine whether or not they would be a candidate for or should receive a particular vaccine in shared decision making. In that process, we also want to gather all information, past medical history, their lived experiences, current medical conditions, their goals, what matters to them, any concerns. And throughout that process, we're talking with them, and we are also offering support and understanding throughout that process. But the first thing is we just need to agree that we need to have a discussion and that we need to make a decision. The second part to the model is that option talk, and that is where we provide, as the healthcare provider, we will usually provide the options to the patient. Now, back to vaccines, option would be to vaccinate or not vaccinate, right? And we're going to discuss the risks and the benefits of each of those options. And a lot of times in true shared decision making, the patient is provided with some sort of educational material or tools to help them better understand the information that we're trying to provide to them. So that can be videos, educational videos, pamphlets, maybe some surveys or surveys for what matters to them, or their quality of life, or even just like different guides to help them to guide them to the decision phase, which is then the last model of that decision talk. And decision talk is where we then weigh the options that we have. And this is where, as a healthcare provider, we are going to let our expertise guide the communication of what we know and our expertise in this area. And we're going to help guide the patient to a decision, and we're going to come to a conclusion, and continue to work together as a team for what the options are and what we want to do in their treatment or their prevention plan. So we're going to just do a quick knowledge check here from what we just covered. Now, you don't need to put any of your responses in the chat or anything like that. It's just if you can think about this on your own, and then I'm going to go over the answer. We'll have a couple of these, so you can just apply that same method as we go through them. So the question is, which of the following is a component that needs to be present to be considered shared clinical decision making? A is the provider must follow a routine recommendation. B, both the patient and provider share information and come to consensus. C, the provider must make recommendations for care. Or D, the patient must listen to the provider. And the answer, hopefully you chose, is B. So both the patient and the provider share information and then come to consensus. The other types of, A, C, and D are a lot more of that one-directional model where the provider is providing the recommendation, and we're hoping that the patient accepts the recommendation that we're providing. So now we're going to go into the application of shared decision-making and vaccines, and also in the realm of vaccines, the term shared decision-making, which is usually used in more of a broader healthcare context, shared clinical decision-making is a term that is usually related to vaccine and vaccine administration. So really quickly, we're going to just review some of the overall vaccine recommendations and approval process. So there's clinical trials that take place from drug manufacturers and vaccine manufacturers. And then from those clinical trials, they then present that evidence to what we call VRBAC, or Vaccine and Related Biological Product Advisory Committee. That committee looks over the information and then provides, a recommendation and their advice to the FDA, which then will go ahead and approve or not approve the vaccine for use in particular conditions, age groups, those types of things. And that's just the actual vaccine approval process from the FDA's perspective. But then how that's applied kind of nationally, and how our immunization schedules, how those vaccines go to be on those, and the overall recommendations from the CDC. Once a vaccine is approved, then that the Advisory Committee on Immunization Practices, or the ACIP, looks at the evidence. And usually the evidence is utilized, or historically speaking, has been utilizing evidence to recommendation and a grade framework. The ACIP themselves get many of those, the members on the ACIP are sitting on ACIP work groups, but the work groups themselves answer particular questions on those vaccines, which we'll get to in a little bit, evidence to recommendation. Now, again, this is all historical. This is not the process that's currently being followed, but historically speaking, this is how we have gotten to vaccine recommendations. And then once the ACIP makes a recommendation for that vaccine, then it goes to the CDC director. And if the CDC director approves that recommendation from the ACIP, which is the usual path that is taken, then those vaccines are then made available to the public, and from the context of like putting on our immunization schedules and all of that. So I talked a little bit about how vaccines are typically recommended. And again, that was like from historical context or previously. And when I had sat on the ACIP work group for adult RSV vaccines, this is the framework that we use to determine what our recommendation was and what our thoughts were to the ACIP when they were making their overall recommendation. And these are some questions that were typically answered. So the first is the disease problematic to public health? So what is our evidence of the burden of disease in society? We look at the cost of that disease to us as society, the morbidity of the disease, the mortality of disease. And many times we're specifically even looking at how that disease is problematic in the group that the vaccine itself has been approved for from the FDA. We also look very in depth as to what are the benefits versus the harm of vaccination. And so benefits can be, the effectiveness, what is the actual effectiveness of the vaccine? What is that vaccine? What would it do for herd immunity? Who also could benefit from the vaccine? As well as those risks. So particularly side effects. Also, upon vaccination, might there be a shift in the disease within the population? We also look at the certainty of the evidence that is available for the vaccination. What types in the clinical trials or real world evidence that we have? What's the effectiveness of the vaccine? How has that been studied in certain groups, like for instance, immunocompromised, where recommendations might be expanded to? And then we also can look at what does that target population think about the vaccination? Are they open to getting vaccinated? Are they knowledgeable about the disease that they might get vaccinated against? And are they open to vaccine? And then, of course, are the amount of resources reasonable to vaccinate a population? So like even like the actual cost of the vaccine itself, also the cost analysis of cost versus benefit of vaccination in the cost perspective. And then what is the impact on health equality or health equity? And meaning that, if we vaccinate a certain population, what would that mean for others who maybe aren't get the vaccine, or is that vaccine available to all that might need it? And then, of course, is it feasible to implement? And so these are the questions that ACIP work groups historically have answered and then made recommendations to the ACIP. And then the ACIP, from looking at this evidence to recommendation framework and the answers to those, typically have made one of three recommendations. So there's routine vaccination. So that means that everybody in a particular age or risk group are vaccinated. There's also catch up, meaning that, if there's a newer vaccine available and people had been vaccinated with a previous vaccine, what does catch up look like, as in the fact of how do you get people the newer or maybe improved vaccine, or how would you get people vaccinated that hadn't been vaccinated before but now need to be vaccinated? And then finally, there's that shared clinical decision-making that we're talking about so much. And so shared clinical decision-making for vaccines was introduced in 2019. And this has been historically taken into if there are benefits for recommendation, or there is benefit for vaccination, but there isn't enough benefit of vaccination for an entire age group or population. And so I will go through in a couple of slides here a little bit of the vaccines that we have shared clinical decision-making recommendations for. But one of those examples is that we can give is the HPV vaccine for individuals 27 to 45 years of age. So when you're looking at the evidence to recommendation framework for that particular vaccine, there are some people in that age group that if they had not been vaccinated with HPV vaccine before, that they can benefit. However, there wasn't enough evidence that that entire age group for all people in the population should be vaccinated. And so that's where that shared decision making comes in, where the provider and the patient come together. They look at their, previous medical history, their, previous sexual activity, and potential future activity, and then come to determine whether or not that individual could benefit from vaccination. So that's just one example, and we'll get through some others here in a moment. And so shared clinical decision-making, again, is individually based and informed by decision process between that caregiver and the patient and or parent or guardian. And this is, unlike, again, those routine or catch-up or risk-based recommendation, it's not recommended for everyone in that group, but it is recommended for certain individuals within an identifiable group. And again, HPV, that 27 to 45 years of age, and then meningococcal B vaccines in adolescents is another good example. It's also really important to understand that shared clinical decision-making is not informed consent. So we talked a little bit about this when we went through that example of the blood transfusion. But shared clinical decision-making recommendations have been traditionally used, again, when there's maybe an individual level benefit versus that broad range. And the type of recommendation is not an approach to individual healthcare. So, understanding that shared decision-making is not the informed consent process where when a patient comes in and you're recommending a vaccine for them and you're telling them, you're handing them the vaccine information statement, we're going through the risk and benefit of vaccine, and that they are giving their consent to get vaccinated based off of the information you've been providing to them. That's more of a process of that patient necessarily like following a recommendation that you're providing to them. And so informed consent takes place with all vaccines, but this is a little bit different into more of that shared decision-making between you and the patient or their caregiver. So now we're going to just take another moment to do a knowledge check. And again, you do not have to answer in the chat or anything like that. But which of the following best defines shared clinical decision-making in the context of vaccination? So A, the clinician recommends a vaccine and the patient agrees. B, the clinician provides vaccine information and the patient independently decides. C, a collaborative process in which clinicians and patients make decisions together based off of evidence, risk, benefit, and patient values. And D, a standardized approach where all eligible patients receive the same vaccines. And again, it's going to be that C, that always going to hear that collaborative process. If a clinician recommends a vaccine and the patient agrees to that, that's more of that one-way model. And you're usually recommending a vaccine based off of a vaccine recommendation of either, wide vaccine, standard recommendation or potentially catch-up. Providing vaccine information for that and the patient deciding to get the vaccine, again, is more of that one direction model, and then also has some components of informed consent in there. And then D, again, that's more of the decision of kind of that blanket recommendation that typically had come previously from vaccine recommendations. So following that evidence to recommendation that we've talked about and going to the example even of that HPV vaccine of that 27 to 45 years of age, we looked at some things as to evidence to recommendations. And so why was that decision made for shared clinical decision making? Well, that evidence to recommendation for that particular vaccine is it problematic to public health? Well, we were uncertain for that age group. Yes, for some individuals in that age group, but we weren't really sure that vaccinating that entire population would be beneficial. Harms versus benefits of vaccine, again, it was variable. For individuals that would really benefit from the vaccine, it was much higher than those that wouldn't necessarily benefit from vaccine. There was moderate evidence and varies and lacking of evidence of the target population and if they would be open to the vaccination. And then, the amount of resources be reasonable, probably not for that particular age group. Then it varied a lot by health equity, depending upon if that individual was really someone who would benefit from vaccination or not. And so these evidence to recommendation frameworks for vaccines that had historically been given the shared clinical decision-making process, the recommendation is all, the evidence to recommendation framework is all available on the CDC's website. And so anyone can take a look at that and review that and exactly know why the shared clinical decision-making recommendation came. However, since we've kind of gone away from that evidence to recommendation framework and process, and now, with these newer updates with shared decision making, there has been kind of, again, that shift of how recommendations are made. And these were made particularly from the HHS secretary, came from the CDC. So there really wasn't any evidence to recommendation framework to follow. And this has created a lot of confusion as well as a lot of uncertainty. And that is why also that many organizations across the United States have not endorsed the CDC immunization schedule that has the vaccines that are highlighted in yellow as vaccines that should fall under shared clinical decision making. Whereas most organizations in the healthcare organizations in the United States are following the AAP schedule, which was, previous of the harder recommendation that these vaccines were recommended based off of the evidence to recommendation framework. And the reason that shared clinical decision making can be really challenging and has been causing a lot of confusion with these vaccines is that there really isn't that, information and evidence to recommendation as to why that individuals, for instance, children 6 months and older, we don't have evidence, we don't have, strong data as to why we should have that conversation with the patient. So if I'm truly following shared clinical decision making with the patient, I should have evidence as to why maybe that 1-year-old shouldn't potentially get the influenza vaccine. And then I should be participating in a shared clinical decision-making conversation of if that patient should receive their influenza vaccine. However, the way that, since we do not have really evidence as to why that 1-year-old should not receive their influenza vaccine unless there's, a really strong contraindication from, previous medical history or that, contraindication that would have already been provided from the vaccine manufacturer and the schedules themselves. It's hard for us to have that conversation because we don't have that evidence as to why they really wouldn't be a candidate for vaccine. So, who would be involved in those shared clinical decision-making conversations? The CDC has really outlined who they are looking for and who should be having these conversations with patients. So primary care physicians, specialists, advanced practice providers, such as physician's assistants, nurse practitioners, registered nurses, and pharmacists. All of these individuals are qualified and are considered a provider in the fact of those who can and should be participating in shared clinical decision-making conversations. And so again, with this model, questions we've also been getting as well, who can give vaccines under shared decision-making? So standing orders are still applying. So particularly if you are an individual who's, following standing orders, if you have standing orders for a particular vaccine, even with shared decision-making, those standing orders are still going to be in place. And then as for pharmacists, it's going to be very state specific. So I'm going to give the example of North Dakota, and please note in the slide that, under North Dakota state law, and that's where Siri is housed, and that's where I'm giving this presentation from. North Dakota state law says that pharmacists can provide vaccines to anyone 3 years and older, and any vaccine that's been recommended by the CDC and the ACIP. However, if your state law is requiring that you're following a particular schedule, such as the CDC schedule, since some of these vaccines that, are now being placed under shared decision making, whereas maybe for that 4-month-old, you might have, if you're operating under a protocol and sorry, not 4-month-old, but 4-year-old. Let's say there's a 5-year-old child that the parent comes in to give the vaccine, versus, telling that individual and that caregiver, oh, it's time for your influenza vaccine. Under the CDC recommendation, ACIP recommendation, we should actually be participating in a true shared clinical decision-making conversation prior to giving that vaccine. And then, of course, shared decision-making also still fits into the framework for public health as well. So our patients still should be getting their vaccines from all these places, regardless of whether it's shared decision-making model or not. So that has not changed anything. Also, vaccines that are provided under shared decision-making are covered by insurance, and that has been a guarantee at least through 2026. So it's hard to know what might happen after that. And then also understanding that shared decision-making and then administering the vaccine are not the same thing. And hopefully, what we've already talked about with shared decision-making and shared clinical decision-making, and you understanding what that is, you understand how that is very different from just the process and the technical process of administering a vaccine. And then, of course, anyone that is eligible for vaccination, we can be engaging the parent, caregiver, or those patients in shared decision-making processes. Unfortunately, there's some consequences from these recommendations. And so the changing vaccine recommendation to shared decision-making falsely implies that there's no clear evidence-based recommendation. And this has come from a quote here. And I think that you can understand why we've used this code and where the concern has been. So when someone sees that a vaccine recommendation has gone from a blanket recommendation of everyone in an age group and all that, it's implying that maybe some evidence has changed, that, oh, we're making a shift now, so we have new evidence, or we have evidence as to why not everybody in an age group or condition should be vaccinated. And there's that assumption that something has changed, but it hasn't. We do not have evidence that is saying that these vaccines should be following under that shared decision making. And also, some parents and caregivers and patients are thinking that, oh, well, now it's that, I'm going to be more involved in my vaccine, in whether or not my child or whether I should get vaccines. That's always been the case. We have always, as healthcare providers, provided informed consent and had the patients involved in their own decisions for health as to if they should get vaccinated or not. And so, this has really provided a lot of this recommendation, I think, across the board, has provided a lot of uncertainty where there once was a lot of clarity. Because again, we do not have the evidence that's saying, like against that evidence to recommendation or any evidence at all that's very clear and dry as to why we shouldn't have a blanket recommendation for vaccination in these particular populations. It's also causing a lot of other confusion. From some surveys that have been provided, only 1 in 5 patients believe that shared decision making means, or 1 in 5 patients believe that shared decision making taking the vaccine may not be a good idea for everyone, but would benefit some. And so again, that's problematic because as we know from the evidence from the vaccines that have been changed, we don't have evidence that is all of a sudden saying that these individuals would not benefit from vaccination. And then 1 in 4 think that shared decision-making means talking to family, which as we know, it's not. Patients have always been involved in their own vaccine administration and whether or not they receive a vaccine. And so this has been problematic. And although a lot of patients kind of understand where they can get or who can participate in shared decision making, a number of vaccines are primarily provided in pharmacies across the United States, and only 33% of those that were surveyed think that a pharmacist can engage in that shared decision making conversation. So that again can be problematic if patients feel like they might not be able to get these vaccines at their pharmacies any longer if they don't feel that the pharmacist can be participating in those conversations, which again is false. The pharmacist is one of the caregivers that's highlighted by the CDC to participate in this. There's also some other challenges to implementing shared decision-making, limited consultation time. And so shared decision-making takes more time than a regular recommendation. And so with resource constraints and the amount of time that takes, that can be more of a challenge. Varying health literacy and diverse cultural beliefs. There's a number of patients who feel that, especially with the lower health literacy, the evidence and literature has shown that when someone has a lower health literacy, a lot of times they just want the provider to make the decision for them. And they don't understand why the provider isn't just making the decision for them and telling them, what they should do. And so when you're shifting to that shared decision-making model, that patient needs to have more involvement in it, which can cause some challenges. And then again, we already talked about how moving to this model for some of these vaccines that have strong evidence of support for blanket recommendations now going to shared decision-making can create misinformation and mistrust because the population, the public is thinking, well, something has changed, when in fact it hasn't. So there's also some other challenges of shared decision-making and unintended consequences, and that means vaccination rates have been historically shown to decrease. A case example is the PCV13 case example, where there was a change in recommendation for a certain population to go to shared clinical decision-making. And in that shared decision-making model, those that were eligible for vaccination, their rates declined by 23%. Now, it's a little harder to have a denominator for when you're using shared decision-making because you're not fully sure as to who all is technically eligible for vaccination. You don't really have that number as strict as you would have for all age groups and individuals in a population. But when we looked at the numbers of people who could receive vaccine compared to those that had previously received it before shared decision-making, there was a 23% reduction. But unfortunately, for those individuals that were immunocompromised that should absolutely receive vaccination, there was also a 21% decline. So what we're seeing is that shared decision-making has historically led to lower vaccination rates. Also, as we know, access to vaccines is problematic nationwide, and access to care. And so moving to this model can also decrease access to care, particularly if we're seeing rates decline. An unintended consequences is some local public health units or pharmacies might stop carrying some of these vaccines because there isn't the demand or there isn't the patient uptake that they used to be. And then all of a sudden, people will have less access to those vaccines. So we have to be really careful and watch for that and make sure that we're still providing these to our patients and engaging in these shared decision-making conversations. And then this just are a couple of slides here that we are highlighting the need for, increased access and access to vaccine and why, going to the shared decision-making model could have unintended consequences. Also, since, we're going to highlight the influenza vaccine here and influenza season right now, and particularly because the 2024 to 2005 influenza season has had the highest number of pediatric deaths since it was starting to be reported since 2004, with the exception of the 2009-2010 H1N1 pandemic. So we've had, as you probably already know if you're a healthcare provider listening to this, it's been 2024-2025 flu season was a really rough season, particularly with pediatric patients. And sometimes people think that, well, the majority of those deaths must have had an underlying condition. Well, we're actually only 1 in 2. So only 1 in 2 pediatric patients that died from influenza had an underlying health condition, and the large majority of those that died were not vaccinated. And so I think it's a really important highlight for us to understand that in an area already where we're seeing a decrease in immunization rates for some of our vaccines like influenza, but we're also seeing an increase with deaths on the rise. Moving this recommendation now to even shared decision-making could potentially even lower our vaccination rates much more. And so really important to understand that even though that we moved to the shared decision-making from the CDC, still a very important vaccine for our patients and to be having these conversations with patients and caregivers. So just a couple of critical points before we get to our last knowledge check. Overall, just some summary. Shared decision making is important in medical care, and with primary care visits often limited to only about 15 minutes, it's really important that everyone in the healthcare team is participating and having conversations of vaccination. Anyone that's involved with that patient and patient's care is participating in that. And if we are requiring social shared decision making for vaccinations, there's definitely some challenges and could potentially create some bottlenecks to care and delayed vaccination for these patients. And so finally, our last knowledge check here, shared clinical decision making is also referred to as informed consent, true or false? And hopefully I talked about that quite a bit. Then you, if you're answering this in your head, you got the right answer, but that would be false. Okay, so I will now turn it over to the moderator to introduce our next speaker. Thank you, everyone.
Thank you, Dr. Skoy, for this wonderful presentation. We've already been getting some questions, so we'll hopefully get to those at the end. I'm happy to now introduce our second speaker, Andrea Polkinghorn. Andrea is the lead immunization strategist for Sanford Health, where she oversees immunization strategy, education, and quality improvement across more than 200 clinics. She also serves as president of Immunize South Dakota and vice chair of the Sioux Falls Board of Health. Andrea is a passionate advocate for vaccines, driven by her personal journey from vaccine hesitancy to immunization leadership. She lives in Sioux Falls with her husband and 3 daughters. Andrea, you can begin.
Thank you. Just looking to confirm, Dr. Newman, you can see my slides okay?
We see them great.
Okay. So as Liz was talking, I thought I needed to add just a little disclaimer. So I want to say I 100% agree with everything that Liz said about shared clinical decision making. My portion of the presentation is more centered on how nurses and medical assistants support shared clinical decision making through the use of protocol orders. The way I look at it, there is a level of risk for some people, which is why shared clinical decision making recommendations exist. And we know that vaccines are safe and not likely to cause harm. So from my perspective, why not make it as easy as possible for people to provide vaccines with this type of recommendation? Additionally, I think the intent of shared clinical decision making versus real life application can be different. And I feel that it is in regards to this type of recommendation, which Liz touched on a little bit. In fact, prior to the overhaul of ACIP, committee members, they often discuss the challenges that healthcare providers have implementing these type of recommendations. They often reference providers not recommending vaccines with a shared clinical decision-making recommendation because providers are unsure about when to recommend the vaccine and for who. I will point out that CDC has developed some nice handouts to help with these conversations, but just wanted to kind of create that caveat before I jump in. Oops. Okay, so I have no financial relationships to disclose. This is a global perspective of Sanford Health, the healthcare system that I work for. So we have 57 medical centers and almost 300 clinics. However, this is our main footprint, located in the upper Midwest and primarily where I conduct most of my work. So nursing protocols, or sometimes they're also referred to as standing orders. These are orders that are standardized, evidence-based, and let nurses perform specific clinical actions when specific criteria are met. They remove the need for an individual provider order by clearly defining who is eligible and exactly what actions the nurse may take. They're often approved by a licensed prescriber and ensure nurses work within defined boundaries rather than making independent clinical decisions. There are a number of benefits, which include faster, more timely patient care, improved access and workflow efficiency, enhanced patient safety, standardized and consistent care, They support higher immunization rates and public health goals, and they reduce some of the workload for providers. There are scope of practice considerations that need to be taken into account when developing protocol orders. So nursing staff and MAs need to ensure they're practicing within the scope of practice, which is determined by each state. Within Sanford's main footprint, all states allow RNs, LPNs, and MAs to administer vaccines per protocol, with the exception of MA3s in North Dakota. MA3s cannot execute a protocol order, conduct medication calculation, or draw up medications from multi-dose vials. So that is one caveat that we have since we operate in North Dakota. Several states we operate in have additional rules for LPNs and MAs, stating that they need delegation by an RN or the provider. Our immunization protocol orders are developed by myself, and I'm a nurse, and approved by our Enterprise Immunization Committee, which is a multidisciplinary committee, and then it goes to the Clinical Practice Committee, which is a committee of providers. Another scope of practice consideration is around patient education. RNs can independently educate. LPNs can educate from pre-printed material, so for example, the VIS, and MAs cannot educate, but they can distribute the VIS and follow up with the provider if there are questions or concerns. We have protocol orders for all vaccines with a shared clinical decision-making recommendation at our health system. So that includes Men B for individuals 16 through 23 years of age, Hep B for adults 60 years and older with risk conditions, HPV for adults 27 to 45, PCV20 or PCV21 for adults 65 years and older who have completed the recommended pneumococcal series with PCV13 and PPSV23, and then the additional doses of COVID vaccine for those who are moderately to severely immunocompromised. One of the things they wanted me to touch on is, did we have to make modifications to our protocol orders with the recent changes from the CDC schedule? We did transition to follow AAP and AAFP, so thankfully we have not had to make changes to our protocol orders. So this is my knowledge check for you. Again, you don't have to submit it, just think in your head what the answers should be. Which of the following is currently recommended under shared clinical decision-making? A, meningococcal B for individuals 16 to 23 years old. B, pneumococcal conjugate vaccine for infants. C, HPV vaccine for individuals 11 to 18 years old. And D, MMR vaccine for children 1 to 6 years old. And the answer is A. So the CDC defines a healthcare provider as anyone who provides or administers vaccines. They specifically list the roles included on the slide. So in the darker blue there, they list primary care physicians, specialists, physician assistants, nurse practitioners, registered nurses, and pharmacists. Sanford's list of roles expand on this to include all nurses, so LPNs and RNs, and medical assistants. As mentioned, LPNs can educate from pre-printed materials, which would include the VIS, and MAs are able to provide the VIS and follow up with the provider or RN if the patient has any questions or concerns. So this is how our health system kind of evolved. Initially, we only had protocol orders for routine and catch-up recommendations. We did expand on that to include shared clinical decision-making, but had it where nurses, and when I say that, I include MAs in that definition, they could only complete a series. They could not initiate it. So I looked into it more, and I provided education to our Enterprise Immunization Committee about the intent of this type of recommendation and who the CDC defined as a healthcare provider. And we did receive approval to expand the protocol orders so that nursing staff could both initiate and complete a vaccine series with a shared clinical decision-making recommendation. As far as staff educate, we educate about shared clinical decision-making anytime that we're hosting education about a vaccine with this type of recommendation. We also recently disseminated information through our weekly staff communications after the CDC schedule changes. So that was another reminder that we disseminated. And then we have a VaxChamp program where we also provide education about this type of recommendation. Internally, we emphasize that all shared clinical decision-making vaccines should be recommended to eligible patients when the provider prompt is flagging in the EHR. If patients aren't informed that a vaccine is available to them, they are unlikely to be aware of the opportunity, and this may result in missed vaccinations among individuals who would otherwise be willing to receive them. And then we also tell our staff that they are to honor patient requests for vaccines with this type of recommendation. So this is EHR, out of sight, out of mind. The provider prompt in Stanford's EHR is called health maintenance. Our EHR is currently flagging for HPV for 27 to 45-year-olds, Men B for 16 to 23-year-olds, and Hep B for high-risk adults 60 years and older. We had the option for our EHR vendor to have HPV and COVID flag. We chose not to have the additional doses of COVID flag. Primarily, this is because not a lot of people are getting their COVID vaccine anymore, except those who really want it. Additionally, these individuals are often seeing specialists who can have the conversation with their patients and provide the vaccine. I'm unsure about why pneumo for adults 65 years and older was not made available per the CDSI rules that are released by CDC. So those are the rules that CDC releases that EHRs take to build in things like provider prompt, but for whatever reason, that was not an option. And lastly, I'll just say that I titled this Out of Sight, Out of Mind because we did have an experience in the past where there was a change with our health maintenance, so the provider prompt, where it had been flagging for everyone 16 to 23-year-olds for Men B, and that went away. And so over a year later, we pulled data and the number of doses administered severely decreased. And so I think it just highlights the importance of having that reminder flag for nurses and prescribing providers, really anyone. I think we're all doing so much every time the patient's in front of us that if we don't have that reminder, it just kind of gets forgotten. Documentation for shared clinical decision-making is really no different than other vaccine documentation. I think it is good practice to document informed decision-making. Additionally, we ask staff to document patient refusal. We have a vaccine refusal section in our EHR, and that section also allows them the ability to document why a patient refused. So was that vaccine not available? Maybe there was a shortage or they ran out. If the patient refused, if the patient was sick, if they financially, let's say they're on Medicare Part D, so they have to go to the retail pharmacy for something, so that we can obtain some data to really observe why our patients are declining vaccines. There is, however, certain information that is required by law to document, including vaccine name, manufacturer and formulation, lot number and expiration date, dose, route, and site of administration, date of administration, name and address and title of the person administering the vaccine, the edition date of the VIS that was provided, the date the VIS was provided, the vaccine screening questionnaire, and the state immunization program eligibility. So the challenges that we had as a health system were really just about people not knowing the intent of shared clinical decision-making, why these types of recommendations exist, and really who is considered a healthcare provider who can execute these types of recommendations. These are my references.
Thank you, Andrea. Thank you both for such incredible presentations. Okay, we have had quite a few questions come in. I know we're almost at time. I'm just going to pick one or two. I feel like this one might be more for you, Liz, but please, either of you feel free to chime in. The first question we received was, shared decision-making is not informed consent. Should it be used when the scientific evidence is not clearly available to support a medical treatment or intervention?
Yeah, so in a really broad context, not necessarily vaccine specific, shared decision making is really an ideal approach if there isn't a really great treatment option. So for instance, I'm going to give that example of maybe like oncology, where you're faced with something that doesn't have a lot of evidence for treatment, or there isn't like a clear best treatment process. Then shared decision making is actually an ideal model to use to come together with the patient and determine what the next course of action is going to be. Now, the other question is, so that process is, if you're asking particularly related to vaccines and the vaccines that we have right now, I think you have to look at what schedule you're following. And so as Andrea just had mentioned, that as their group and their organization has chosen to follow the AAP guidelines for that. And so in the ideal world, and where historically speaking the vaccines have had evidence as to why they have that shared clinical decision making. If you are following in a model where shared clinical decision making needs to be applied to vaccines, I think in that expert context, your expert in that decision, when you're coming to the table with the patient, is explaining to them, why it is that from your side of you, they should get vaccinated based off of this information, and still having that conversation with them. So I really think that maybe the approach isn't really changing that as much. But there again, I think that in shared decision making, you use your expertise as a healthcare provider when you're coming to the table, is that the evidence behind those vaccines. But I would agree that with these recommendations where the evidence hasn't changed, it can be challenging how to really accurately apply shared decision making.
Thank you for that, Dr. Skoy. Maybe this was for both of you. There was kind of an interesting one. Someone asked about, what about administration by pharmacy technicians? Many retail chains authorized pharmacy techs to administer certain vaccines, and this appeared to be a success, maybe during COVID or during the pandemic. Do either of you know or have opinions about that as vaccine providers?
So as a pharmacist, I can speak to this. So absolutely, pharmacy technicians in a lot of states across the country can administer vaccines. However, when it comes to more of that shared clinical decision making, kind of similar to how Andrea had mentioned how they utilize shared decision making in their context, it would be the pharmacist who would be engaging in the shared clinical decision-making conversation, but yet the pharmacy technician would be the one that would be administering the vaccine. So I think there is that difference between administration and that shared clinical decision-making.
That makes a lot of sense. There was a very similar question about how can MAs act under protocol to do, but I think it's probably a similar answer. MAs are not the ones doing shared clinical decision making; they're just administering the vaccine. Is that correct, Andrea? Am I understanding that right?
Yeah, so the MA would use the protocol order for patient-initiated requests for a shared clinical decision-making vaccine. And also, we just have more of a proactive approach for things that are showing as overdue. Like I said, we have them almost all of them flagging in the EHR to recommend them. And then if there are questions or concerns expressed, then the provider would be consulted.
Okay, well, in the interest of respecting everyone's time, I know we're even a little over. Thank you guys again for sharing your expertise today. Thank everyone in the audience for joining us. We look forward to seeing you again at our next webinar.